the disease with 1,000 faces. Difficult to diagnose, complex, and chronic. It will strike 1 in 900 Canadians. Lupus. This autoimmune disease alters patients' lives, and if left untreated, can be fatal. At the BC Lupus Society, we provide support to people living with lupus. Because lupus is unpredictable, we strive to be dependable. Our programs include weekly support groups for patients and families in British Columbia. We make sure that educational resources and peer contacts are always available, including for patients facing a new lupus diagnosis. And every year, we help fund clinical training and medical research that benefit people with lupus. Through the BC Lupus Research Scholar Program, our goal is to advance treatments and discoveries to change the future of lupus. Our partnership with university researchers is unique in Canada and has helped understand the full impact of lupus and the effectiveness of lupus care. As part of our community, you're a valued part of annual events like our Lupus Gala and the Shed Light on Lupus Walk. These fundraising activities generate just part of the funds needed to sustain our work in patient support and medical research. With the generous support of donors like you, the BC Lupus Society will continue to be here for patients and families affected by lupus. Not only can we change tomorrow, we can brighten today. Thank you from the BC Lupus Society.
Hi, everyone. I'm Dr. Antonio Avina-Zubieta. I'm an associate professor and head of the Division of Rheumatology at the University of British Columbia and the BC Lupus Society Research Scholar. I am also a senior scientist at Arthritis Research Canada. Welcome to the traditional BC Lupus Society Annual Symposium. Today, I am going to present data of my most recent research on the risk of developing autoimmune diseases, including systemic lupus erythematosus after COVID-19. I have nothing to any conflict of interest for this presentation. As you know, COVID-19 is perhaps in some places still an ongoing public health crisis, with some peaks during the year, and there is still people being admitted to the hospital and still some dying after contracting this disease. We know that patients with rheumatic diseases have an increased risk of COVID infection when compared to individuals without rheumatic diseases, probably because of the therapies that they take and also because of the autoimmune dysregulation that these people have. We also know from previous research that I had the privilege to present at the last annual symposium that people with rheumatic diseases have adverse outcomes when they develop COVID-19 infection when we compare to people without rheumatic diseases. And this is some of the data that we presented last year, just as a quick reminder and refreshment of the data. So in particular, for lupus, which is in this row, we found that the risk or people having lupus have a higher risk of 88% of being hospitalized because of COVID compared to people who did not have lupus but also have an infection of COVID. These are other diseases associated, but we're going to keep focusing today on lupus. So lupus have being associated with 88% increased risk of being hospitalized if they have COVID-19. So how about admissions to intensive care units? Again, when we group all rheumatic diseases that belong to the group called systemic autoimmune rheumatic disorders, or also known as SARS, which includes lupus, Sjogren disease, systemic sclerosis, autoimmune inflammatory myositis, and vasculitis, all together when we group them, we saw an association of 74% increased risk of being admitted to ICU. People with lupus, that you can see in this row, the point estimate suggests that they have a 67% increased risk of being admitted to ICU, although the 95 confidence interval crossed number 1. Therefore, this is not considered statistically significant, and this is most likely because the number of cases was small. How about mortality? People with lupus who had COVID-19 have the point estimate suggest that less risk of being dead after COVID-19. However, the 95 confidence interval is quite wide, suggesting that the small sample size may not allow us to have an accurate estimate. So for the purpose of this study, for the new study, this is the background. We know from previous reports, especially case series, that there is an association of an increased risk of developing new autoimmune disease after having COVID-19 infection. The rationale for this hypothesis is we know that some viruses are triggers or being associated as triggers of developing autoimmune diseases. Among those viruses include Epstein-Barr, Coxsackie, cytomegalovirus, and enteroviruses. In particular, SARS-CoV-2 virus, which is the one that provokes COVID-19, is known to be a retrovirus. And we know that retrovirus have been associated with an increased risk of developing autoimmune diseases, including lupus, probably rheumatoid arthritis, and other autoimmune diseases. Previous studies or large studies that have been previously published include mainly 3 large studies, one from the US that found an increased risk for 14 autoimmune diseases with a risk range from 78% to 300 times or 300% increased risk. Another study from Hong Kong assessed the risk of autoimmune diseases in 11 autoimmune diseases, and the risk was from almost 30% to 266%. Again, another different study from Europe in Germany found an increased risk of 43% compared to people who did not have COVID infection. Again, the range was from 37% to 48%. So this suggests that there may be an association of COVID infection and then a subsequent risk of developing a new autoimmune disease. With this hypothesis in mind, we wanted to explore the risk in our BC population. Therefore, the objective was to see if having an infection by the virus that provokes COVID-19 will be associated with a new onset of an autoimmune disease compared to individuals who did not have COVID-19. For this study, we used the health administrative data from the Minister of Health. As you may remember from previous research that I have presented, I have used the same data. In BC, all individuals that have a healthcare encounter in the province generate a record, and therefore we're able to have a longitudinal measurement of the healthcare exposure, including hospitalizations, visits to medical doctors, prescriptions of medications dispensed by a pharmacist, death, cause of death, cancer, emergency visits, etc. So we use this data set to investigate the hypothesis in mind. So in this study, we include all population of BC who had been infected by the SARS-CoV-2 virus from February of 2020 to March 2022. This is the period where it was mandatory to be tested by PCR, which is the gold standard to diagnose an infection by this virus. After March 2022, it was not longer mandatory to get tested for this infection. Therefore, this is the only period of exposure, and then we follow all cases up until December 2022 to see if they develop an infection if they develop an autoimmune diseases. Individuals who had a previous autoimmune disease were excluded from the study. Therefore, we were certain that they did not have a diagnosis for at least 7 years prior to being infected or having the COVID-19 disease. For all individuals that were positive for a COVID infection, we matched them with 3 individuals who were tested for COVID-19, but they were negative. And we matched them on same age, same sex, same location, and by the month and year of the diagnosis of the infection. We look for the risk of 34 different autoimmune diseases following the infection of COVID-19. So we did very complex analysis and adjust for different important factors, which means we remove the potential role of all these variables to find out the solo effect of having an infection disease by COVID-19 and the risk of potential new onset of autoimmune diseases. So we run 34 different models for each autoimmune disease. Again, we exclude all individuals who at the time of COVID-19 already had an autoimmune disease prior to COVID-19. And this is the main characteristics of the population. We identify 257,000 individuals infected by COVID-19 with a mean age of 45. More or less half of them were female. And this is the distribution of the socioeconomical status, where the highest percentage, the quintile 5, is the people with the highest income based on the neighborhood that they live. This is with the number of outpatient visits in the last year prior to COVID-19. And we can see that none of those in both groups had a previous hospitalization. prior to the COVID-19 infection. Same, none of them have on median a visit to an emergency hospital. So this used to show that the matching was, in general, well matched between the two groups. Now, this is the risk of developing new onset of lupus after a COVID-19 infection. This is the rate for every 1,000 patient years of follow-up, meaning if we had 1,000 patients and we follow them for 1 year, 1,000 patients with COVID-19, and we follow them for 1 year, only less than 1 or 0.14 have a new onset of lupus compared to 0.15 among those people who did not have a COVID-19 infection. In other words, the risk was very similar, suggesting that there is no increased risk of lupus. If we see this in another way that is easier to interpret, it would multiply, instead of 1,000 years, we multiply by 10,000 years. If we follow 10,000, if we have 10,000 individuals and follow for 1 year, that means 10,000 person years, we will have 1.5 case and 1.5 case in the control group. Again, the rate over time is the same, and therefore there is no increased risk of developing lupus, at least during this follow-up time for developing new onset of lupus. This is all the other diseases that were statistically significant. Surprisingly, patients with COVID-19 have 20% increased risk of developing rheumatoid arthritis after COVID-19. They also have an increased risk of developing immune thrombocytopenic purpura, which is often seen as the initial manifestation of lupus. However, in this particular case, was just thrombocytopenia or low count of platelets post-COVID. Other autoimmune diseases that are also seen as single manifestations of lupus include transverse myelitis, which was significantly increased. And this could be the initial manifestation or could be presented also in lupus patients. However, this is just solo manifestations, and these individuals did not fulfill diagnostic of lupus. In summary, no increased risk of lupus after COVID-19, but there are some increased risks of some autoimmune rheumatic diseases. And this is the graphic representation of the previous data. You can see lupus is in this line, and any point estimate, meaning the dot that is below 1, is not considered an increased risk of the disease. Any point estimate that is beyond 1 or higher than 1 is considered an increased risk or could be considered associated with an increased risk. The bars around here are considered 95 confidence intervals, and they should not cross 1. When they're too wide, like the bottom one, the last one, may suggest that there is a small sample size and the estimate is not as precise. However, if we repeat the experiment 100 times, the point estimate will be falling between these two extremes. As long as the lower end of the extreme does not cross 1, it's considered a statistically significant association. So, in this large matched cohort study of the entire province of BC, we found an increased risk of autoimmune diseases post-COVID-19 infection. Among those diseases, rheumatoid arthritis, thyroid disease, immune thrombocytopenia, transverse myelitis were associated with an increased risk. These findings are very similar in line with previous research. However, we don't know what is the potential role of the different variants of the COVID-19 infection on the risk of these autoimmune diseases, because we did not have data on what variant of the COVID-19 patients were infected with. We have adjusted for different covariates, and therefore we remove all the potential effect of all the relevant factors that could influence the risk. We don't know what is the mechanism, but hypotheses previously known include molecular mimicry, meaning the viruses may contain similar structures molecularly that resemble some components of our own tissues, and the autoimmunity developed, or the immunity that is naturally developed to fight the infection, wrongly recognize components of our own body, and therefore creating autoimmunity. Another effect has been bystander activation. Bystander activation meaning just by accident, or infected B cells that are supposed to die after fighting the infection, they don't die and continue with the autoimmunity. We have included different diseases that were not included in previous studies. However, most of the diseases were not, or data did not show an increased risk, especially for the diseases of interest, like lupus and related diseases. In conclusion, we can say that in our study, we find an increased risk of new onset for autoimmune diseases, but the risk is variable. We found no evidence to support an increased risk of developing lupus after an infection of COVID-19. And the clinical implications for long-term management of patients with COVID-19 infections still remain that early detection and intervention for potential autoimmune diseases once we know that there is an increased risk. Therefore, we should be vigilant and looking for these autoimmune diseases after COVID-19. Finally, I would like to acknowledge all the funders for this research, which include the Michael Smith Foundation. We got funding to do this study. We also would like to thank the BC Support Unit for giving us funding to engage patient partners in study design, interpretation, and publication of our data. We also like to acknowledge Population Data BC for facilitating the access to the data in a timely manner. Of course, this research cannot be done as a solo individual. It requires a research team, including patient partners and knowledge brokers. Thank you. And I'll be happy to answer questions at some point when we see each other, or you can email me or let the BC Lupus Society share of this symposium, and I'll answer those questions. Thank you for your attention, and I wish you health and happiness. Stay well.